Hello everyone. We are just gonna wait a couple more minutes to get started. I am seeing people are just start to get into the session.
All right, I guess let's get started and then people can filter in as they get out of class, etc. Um, so yeah, we'll get started now. Hi everyone, thank you so much for being here today for the second HAS online webinar series of this year. We are absolutely thrilled to have Summer Gentry joining us from NYU. She's coming from NYU Grossman School of Medicine, where she's the co-director of the Center for Surgical and Transplant Applied Research. She has been working in transplant for a long time and has done work in internationally with policy implications using tools of optimization and simulation, et cetera, to really drive impact in transplant in the US and abroad. And so we're going to learn a little bit about that work today. And with that, Summer, I'll let you take it away.
Thank you so much. And again, thanks for the invitation. Thank you to everyone who took time to be here today and hear about this. I love to give talks that are just kind of like what's been on my mind lately. And I realized that it was nagging me. I had been working on this problem of non-use of donated kidneys. And something just wasn't fitting right. And then I realized, oh, this is actually a wicked problem, which is an old traditional idea within operations research. So a couple of things I hope you'll learn from this talk are the construction of wicked problems and like why it's important to recognize when you're looking at a wicked problem in operations research, and also maybe like just embed you in a whole bunch of the really detailed clinical realities of transplantation and why it takes so long to become embedded in this field enough to understand the content well enough to make these kinds of operations research models. I'll just start my story here. So people who have passed away or their families have given authorization for their kidneys to be donated to someone who needs them. A lot of those kidneys are recovered. So they're actually recovered from the deceased donor's body and not transplanted into a recipient, which is really sad for the families. And it's sad for the people who could have benefited from those kidneys. Absolutely universally, the physicians tell me a lot of those kidneys that didn't get transplanted into a recipient would have benefited somebody who is waiting on the list. So what is happening that those kidneys aren't getting transplanted? Well, so we'll start the story with saying that every donated kidney is not the same. The donated kidneys vary a lot in quality. And some people who are waiting on the transplant list are waiting for the very, very, very perfect kidney, whereas others on the transplant list, they might be older, they don't have time to wait 5 years for a kidney to become available, they should be accepting a kidney from an older donor, say. But what happens in practice is the deceased donor allocation system doesn't assign a kidney to a recipient. It offers the kidney to the recipient, and almost all the time, the potential recipient says no. So the physicians are being selective and they're saying, is this the right kidney for my patient? In the end, like less than half of 1% of all kidney offers are accepted. But in 2025, 30,000 kidneys were recovered and 9,000 of them were never transplanted into anybody. And this is just seen as a real urgent thing to deal with in transplantation. You know, we want to honor the gift that the donors are giving. What actually happens is after you recover the kidney, then you start making the offers to people in priority order according to who is the highest priority for getting that kidney. And while those offers are made one at a time, the hours tick by and the kidney's quality degrades while it's waiting on ice. For every additional hour that it waits, there's a higher risk of graft failure. And after 30 hours, 40 hours, there's not like a strict cutoff, but after 2 days of trying to find someone to receive this kidney, it won't be viable anymore and no one will be willing to accept it. So that's basically how this happens, is that the offer isn't getting to the person who would say yes soon enough. Instead, we're waiting for people to say no above you down the line, and it's not getting placed. So kidney non-use is a wicked problem. And this is a quote from the 1973 paper. We use the term wicked kind of meaning akin to malignant or tricky, not in the sense that like it's evil, but it is kind of evil or morally objectionable to not recognize when you're looking at a wicked problem and to treat it as a tame problem. And this is something I actually see sometimes in the operations research literature is someone solving what they should be thinking of as a wicked problem, as though it were a tame one. So I'm going to give you a contrast. I'll show you what I think a tame problem in operations research applied to transplantation is. So for example, there's this research I did designing a composite allocation score for liver allocation. So this picture is intentionally misleading. The optimizing liver allocation is not an assignment problem. Again, we never are able to say this liver goes to this recipient. Instead, we just are ordering the list of potential candidates who could get that liver, and each one of them says yes or no. And actually, one of the hardest things to do in designing allocation is to figure out, if I set this list of priorities, if I sort the candidates in a certain way, who is actually going to get transplanted and who is not going to get transplanted under that system. So that's why we have a detailed, clinically accurate, as much as we can make it, simulation of organ allocation. And here you have the events in this discrete event simulator are in the blue circles. So for instance, somebody gets added to the waiting transplant list, that's listed. An organ becomes available for transplant. That's the bubble that says organs transplanted. Actually, can you see my mouse? That's an interesting thing for me to know. No. Okay, great. All right. Anyway, the match run, that's what I was saying, the sorting of all of the candidates. And so which person are you going to offer it to first? If you offer it to someone and they say no, then you offer it to the next person on the list and the next person on the list, etc. And part of our model includes, after the person receives the graft, maybe that graft fails, maybe they go back on the list to get another liver transplant, etc. And so we can, the yellow boxes are the submodels that are usually usually linear or logistic regression models that kind of tell us what we think will happen. So for instance, there's this organ offer acceptance model that says, if I offered it to you, are you going to say yes or not? And that's really the puzzle and the reason we go to this very detailed organ simulation to try to figure out, okay, if I want to design a liver allocation system, how should I do it so that the people I think should get transplanted will actually get transplanted? So what happened was they wanted to redesign liver allocation, and actually they want to redesign every organ system to use a continuous allocation which is that here's the what's on the screen right now is the classification base. That's what they have now. And it essentially says you have these concentric circles. Status A is the highest urgency for a liver. You're trying to get the liver to the person who is at most risk of dying if they don't get the liver. So we give it to all the status 1 people within 500 miles. And then according to your MELD score, a higher MELD score means you are at risk of dying if you don't get a liver transplant really soon. So we give it to the person with the highest MELD score who's within 150 miles. And then give it to the person with the highest MELD score within 250 miles. And if nobody with a super high MELD score wants it, then we go to a slightly lower MELD score tier. So this is like looks like a hierarchical ordering of objectives. And you can see there are weird edge effects, and people got kind of upset about the idea that, well, but if I was 151 miles away, I wouldn't be in line for this liver, but if I was 149 miles away, I would be, and that doesn't seem right. So continuous allocation started out as an idea of, okay, your priority should gradually decay as you are farther and farther away from the organ. There's good reason to try to get the organ placed nearby because, again, the number of hours it's spending on ice is degrading the quality of the organ for the person who eventually receives it. So they wanted to get rid of this classification-based thing and go to a composite allocation score, which is a weighted combination of objectives. And we don't know what the weights should be. But as I was saying, proximity, the very bottom picture here, proximity is going to be like a sliding scale. Like if you're 151 miles away, you're only a tiny bit lower in priority than if you were 150 miles away, instead of there being these strict cutoffs. Of course, it's not just measuring distance as a sliding scale. Now everything has to be a sliding scale. So every aspect of the allocation system has to be redesigned and put into a score that is basically, as I said, a weighted combination. Here I'm looking at a weighted combination of 5 things. The MELD-PELD score, which I said is how sick you are. If you have a high MELD score, you're likely to die quickly if you aren't able to access a liver transplant. So this is livers allocated according to the rule of rescue. We're trying to make sure nobody dies on the waiting list. So you give it to the person with the highest MELD score. And then you have some weighted combination of other coefficients, the ABO compatibility, because blood type matching is very difficult in transplantation. You have age, which is really just a benefit for pediatric candidates because we really don't want pediatric candidates to die on the waiting list. We're giving them higher priority for the livers. And the design problem, what I'm saying is a tame problem, is figure out what the alpha, beta, gamma should be to make this system do what I want it to do. What do I want it to do? Well, in this case, it's pretty simple, actually. We want it to not be so disruptive to the existing order. So we want a lot of the distributional aspects of this score to give livers mostly to the same groups of people that were getting them under the classification based, but now we have gotten rid of these harsh 150-mile cutoffs. So we used simulation optimization to design these weights, testing 10,000 possible values of what those weights could be, minimizing the number of deaths on the waiting list, and then putting into the constraints things like, well, we don't want the livers overall to travel a whole lot farther than they are under the current system. And we want the number of pediatric transplants to stay similar to what it is in the current system. So at present, kids are built into the classification-based system. It's not obvious, should I give them 10 points or 50 points? And the alternative to using simulation optimization was literally the committee sitting around a table saying, let's put 5 points on that number and then 20 points on that number, without kind of guidance about how would that impact who gets the transplant in the end. So we're arguing that we should use simulation optimization to solve this problem. And in the constraints, I'm basically saying I'm not actually overall trying to massively change the system. I could say in the constraints, I could say actually what I want is more pediatric transplants, or actually what I want is the livers to go a little bit farther than where they are going now. But essentially, now I can describe what I want the outcomes of the allocation to be. And I use an operations research method, which is simulation optimization, to just set the weights in a way that answers that need. And here's the genetic algorithm that we use. Of course, we don't have performance guarantees, but we can design a set of weights. We find an alpha and a beta and gamma so that the distribution of livers isn't too far off from where they're going now, but also we are now eliminating the 150-mile harsh boundaries, and minimizing deaths, and we're able to get fewer deaths overall. So these are the score weights that we designed in this, what I'm calling a tame problem, because I was able to say, what defines a good answer to this problem? And use an operations research method to achieve it. So for instance, in this case, we showed that the number of pediatric deaths was lower under our composite allocation score. The second column is our score. Acuity circles, AC, is the classification-based system that I showed you at the beginning, where they have the 150-mile cutoffs. So we have fewer pediatric deaths. We have about 100 fewer deaths overall per year of people who are dying on the liver waiting list. And we are achieving that, kind of like the same number of transplants for these subcategories. So we're just checking and making sure that by using this composite allocation score to replace the classification-based system, that we're getting the organs going essentially to where we had hoped they would go. Well, I don't have the number of, oh yeah, I do have the number of deaths. So that was a success, and I considered it a tame problem because we can now show that we are happy with this solution. That, the physicians look at all of these little detailed outcomes and they say, well, what about my population? What about women over 50? Did they get transplants, etc.? We can answer all those kinds of questions with this simulation. So this is a tool that's been used for a really long time, discrete event simulation, within the transplant policy circle to decide on these allocation changes. But right now I'm trying to apply it, these discrete event simulations, to try to decrease the number of organs that go untransplanted. And why am I going to argue that decreasing kidney non-use is really a wicked problem? So the number of kidneys that are recovered but not used really took off all of a sudden. So recently, this is so much more of a focus since about 2020, 2021. The number of kidneys that were recovered and not transplanted tripled from 3,000 a year to 9,000 a year. And what are some of the reasons why that happened? So we looked at possibly two reasons why that might have happened. In December 2020, so right around the beginning of 2021, CMS threatened the organ procurement organizations that they had to increase the number of transplants they were doing, or they would be out of business. Essentially, CMS said, we're going to shut you down and give your business to a competitor, because all of these are federally licensed groups that say you can collect all of the organs from Alabama and get them to the people who need them. So they were under a lot of pressure to increase the number of transplants. And at the exact same time, March 15th, 2021, kidney allocation changed from being DSA-based to being circle-based. And DSAs were donation service areas. They were historical boundaries, not quite state boundaries, because if you look at the map on the left, you can see Texas is these three weird, even non-contiguous DSAs. But essentially, they were historically determined boundaries of where those OPOs were collecting organs. And instead of offering organs to all the transplant centers in your DSA, now you have to offer organs to all the transplant centers within a 250-mile circle of you. And generally that means a lot more transplant centers than were in your DSA. So now your kidneys are going farther away. You're working with hospitals you've never worked with before. Maybe there were more delays. That kidney allocation change, a lot of people said it's because you changed kidney allocation that now we have all of these kidneys going untransplanted. So we wrote a paper where we were trying to figure out what were the contributors of these various factors. And in the 2 years before CAS 250, the non-use rate was 21%, and then it shot up to like 28%. And if the old rate had continued, 2,300 more kidneys would have been transplanted. So we said, okay, out of those kidneys, a third of them didn't get transplanted because CAS 250, that circle thing, made allocation slower. And the added hours on each kidney meant that that kidney couldn't be transplanted. And actually 43%, so not 1,000 of those kidneys, didn't get transplanted because the OPOs were recovering kidneys from donors that were more marginal. Donors that were older, donors that had high serum creatinine, which means their kidney wasn't working super well at the moment they died, donors that were donation after cardiac death. All of these things make it harder to accept the organ. And the OPOs were aggressively going out and asking for permission and putting more kidneys into the system that were not quite as ideal for transplantation. And then some of that non-use was an unexplained gradual upward trend in non-use, which we think might be also non-ideal characteristics that are probably not captured in our data. Things we don't know about, but that make those kidneys not quite as good. So it doesn't really overall sound like a bad thing for the OPOs to go out and aggressively ask for permission from a lot more donors, hoping that some of those donors will get placed. And it turned out that the number of kidneys recovered had doubled in this period. So we asked for 15,000 more donors, and 9,000 of them got transplanted, and 6,000 of them didn't get transplanted. So that's not a bad thing. The number of kidney transplants increased from 12,000 to 21,000 in that period I'm talking about from 2020 to 2025. So really, it's kind of a story of everyone is concerned that these kidneys aren't getting transplanted. But we're transplanting 9,000 more people every year, so that's a really good thing. And so recovering non-ideal kidneys is excellent. It means that some of them will probably get transplanted, and it'll probably increase the non-use rate. So maybe non-use rate isn't a very appropriate metric to be focusing on. Maybe we should be focusing on what gets a larger number of transplants done. But at the same time, this paper that I wrote about, that I'm telling you about, it did tell me that those circles and the process of calling hospitals, waiting for them to say no, blah, 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 it was actually getting worse. And there were kidneys that should have been transplanted that were not getting transplanted because of the delays. So what are we going to do about that? It still indicates that there's a problem that could be solved and more of these kidneys could be transplanted. We looked at that, we drilled into the CAS 250 effect and looked at the cold ischemia time at last offer notification. How long is it actually taking before we manage to get the kidney transplanted or the kidney becomes non-used? And all of the CAS 250 attributable increase in non-use was accounted for by the increase in cold ischemia time. So yes, it's because of delays in the new circle system. Okay. So why am I saying this is something I have to think about in a different way than the designing a liver allocation system that I told you about before? There's no definitive formulation of a wicked problem. To define a wicked problem, you need an exhaustive inventory of conceivable solutions. So we kind of hadn't been thinking of the solution as being, well, tell the OPOs only to recover perfect kidneys that are definitely going to get placed, right? Or there's sort of like no way to say exactly what problem am I solving? Am I solving the problem of can I get more people transplanted? Or am I solving the problem of can I eliminate the disappointment of someone who's donated a kidney and then finds out that no one received a transplant from it? And wicked problems have no stopping rule. No stopping rule is super important. What's the right non-use rate? What's the correct number of kidneys not to get transplanted? I don't know what the right answer is. Should it be, maybe there's 5% of kidneys that are recovered that really can't be transplanted. And I do hear, likewise from physicians, while they are telling me there's certainly kidneys getting thrown away that would have been useful for somebody, but they've also told me this offer I got last night should not be transplanted into anyone. It is not a usable kidney. So there's some number that's the right number of non-use, but we don't know what it is. And I don't think we could really define that. the solutions trigger ripple effects. So once you, um, yeah, there's a lot to say about that, but essentially, once you implement an allocation change, you're like irreparably changing a lot of people's lives, and that's in number 10 too. The planner has no right to be wrong. The planners are liable for the consequences of the actions that they generate. A lot of people are kind of mad at me about the kidney circles allocation system. I did not design the kidney allocation circle system, but had written a lot of papers pointing out that the donation service areas, the old system, was creating inequities in availability of kidneys for different people in different states. So, for example, once you change the system, like things start being in motion that kind of aren't reversible. Um, no enumerable set of solutions. And so I'll say what happens really is you end up having to, now I have to incorporate something else into my simulation. This is a new simulation that we designed to try to solve the problem of non-use. Instead of Instead of just saying out of all of the organs that were transplanted, they might have gone to different candidates if I had offered them with a different allocation policy. Now I'm going to say some of the organs I have to include in my modeling all the organs that were recovered that weren't transplanted. This was literally not part of the discrete event simulation model before the most recent iteration. And we have to try to figure out, as you are offering it to all of these different people, at what point does it become non-used? It wasn't in part of the simulation before, and so that is part of a description of how wicked problems become you have links tying into another part of the system that you had thought you could isolate. In the structural framework, it's less apparent where the problem centers lie. Is the problem that the OPOs are recovering kidneys that they shouldn't recover, or is the problem that the physicians aren't answering their phones quickly enough? Is it the problem that they're not sure of whether it's the right kidney? The waves of repercussions, we are no longer surprised to see that a solution is introducing a problem of greater severity at some other node. So they put pressure on the OPOs, you should recover more kidneys. And now we see a bunch of kidneys that were recovered and that can't be used. So you have to enlarge the boundary of the system. And now we're asking about kidneys that didn't get used. And maybe soon we'll also be asking about kidneys that didn't get recovered. There were other donors that the OPOs could have gone out to find in the system. Okay, so to get into the clinical detail of why these things happen, there is heterogeneity in center aggressiveness. So some transplant centers say yes to a bunch of not perfect kidneys. Those are the centers in the red on the right side of this diagram. They take kidneys from donors over 65. They take kidneys from people with terminal creatinine over 2.5, means the kidney's not working at the time the person dies. They take kidneys from Hep C positive donors. Luckily, we now have a curative treatment for hepatitis C. So some transplant centers actually give their patients a hepatitis C positive organ and then treat them for hepatitis C, and that's better than not getting a transplant. Cold ischemia time over 24 hours. But some centers, the ones in the middle, they take some of those non-ideal characteristics, but they don't take any kidneys with cold ischemia time over 24 hours. And then there's the centers on the very left that would say no to all of those things. And the problem is that the offering scheme does not account for, are you the kind of center that's going to say no to a 24-hour-old kidney? We probably shouldn't even make those offers. So that's what I'm going to get into as some of the solutions to this problem. Variation in organ quality, the non-transplanted kidneys are here in the blue. So they really are kind of worse on this kidney donor profile index. Kidney donor profile index is not perfect. It's one-dimensional way of measuring good kidney, bad kidney. But there's plenty of kidneys with a low kidney donor profile index. So on paper, they look like great kidneys and they don't get transplanted. And we don't understand why there is this thing happening. But it's also true that if you are looking at a non-perfect kidney, a kidney with KDPI above 90, it doesn't belong in a young recipient ever. And it should go into a recipient who's older than 50 and who looks like they're going to have to wait a really long time to get a better offer. So this is an example of just like an older paper we wrote that tries to figure out like who should and shouldn't say yes to some of these non-ideal kidneys. The problem is this is sort of framed as the physician, when they get the offer, they should say no to it. But it's not incorporated at all right now into the offering prioritization. We don't say, hey, here's a kidney that doesn't belong in a young person. Let's not offer it to a young person. And I'm arguing that those types of um, offering rules should be in the policy. And it takes a long time to evaluate a marginal organ offer. In fact, on the weekends, more of these kidneys get thrown away just because staffing at the transplant centers. So, how can we figure out a better allocation ordering policy so that fewer kidneys end up not being transplanted after they're recovered? So we used this new simulation that I was describing to you to try to test some ideas. One of them is, let's do it like eBay. If you have a kidney that's not really great, let's just say to a whole bunch of people at once, do you want this? And whoever raises their hand, they get it. And then within like 1 or 2 hours, if nobody wants it, then we offer it to a new group of people. And this is kind of a busy slide, I apologize, but essentially what we were saying is any center within 250 nautical miles, we'll just offer it to all of them at once, but give them a very short time window to answer. So you have to answer within an hour and say, yes, you want it or you don't want it. And if many people say they want it, then it just goes to the candidate with the highest priority who said yes. And if nobody in that 250 nautical miles wants it, then we'll offer it to another group of people simultaneously. It's kind of odd to think that that's not how this works right now. That's not how this works right now. Right now, it's one center at a time. If you are primary, you have a half an hour clock ticking. And within 30 minutes, you have to say yes or no, but only if you're the person at the top of the list. So you can imagine with 100,000 people waiting for a kidney, there isn't time to wait for every single person to take half an hour to decide. So the way that this would speed things up is that the cold ischemia time wouldn't be so accumulating so quickly as we go through this person said no, this person said no, this person said no. And so we simulated this and we think it would decrease non-use from 21% overall to, and I'm sorry, my thing is in the way, from 21% overall to about 12% non-use. And the worst kidneys, the kidneys with KDPI over 75, right now, half of them aren't used, 56% of them are not used, and we think we would only have 20% of them not used. So this is a promising policy. The physicians would say, oh no, this is going to ruin my day because I'm going to have so many offers flying at me all the time. It is going to increase my burden of offers. So we did some work to try to figure out, is that true that they would be spending a lot of their day looking at these not very great kidney offers and seeing if there's anyone on their list who is the right recipient for it. So we think under the existing policy, you're probably getting like 250 offers of kidneys every month. How many is that a day? I'm having trouble dividing by 30, but it's a lot of offers. The people who are on organ offer call are also the same people that are doing the transplants. And there's only usually one of them on call. So they're also doing transplants all night long, accepting offers all night long. This is a true potential burden of it, but so we're looking at ways to decrease that. But essentially, that's one way of doing it is to give simultaneous offers and for those offers to actually expire for everybody. It's never been tried. Although we've been arguing for doing it for about 6, 8 years now. Another thought that some people have is dealing from the bottom of the deck or targeted kidney placement. This is two different systems, by the way. Dealing from the bottom of the deck is the name of a system that someone suggested, which is take a really non-ideal kidney and offer it to the person who has the lowest priority. They would be the last person you would offer it to, but give it to them first because they're the person who is never going to receive a perfect ideal offer. And maybe they're going to be willing to say yes to it. So that's offering marginal kidneys in reverse order of waiting time, dealing from the bottom of the deck. Another way to do it is something we're calling targeted placement, which is in descending order of predicted acceptance probability. And this is a really neat idea because remember I talked about some centers are willing to accept a kidney from a donor over 65, and some centers almost never say yes to it. And yet in the current system, we don't have any way to say, here's a kidney from a donor over 65. Let's only offer it to the person who's likely to actually take it. So in descending offer of predicted acceptance probability would kind of send non-perfect kidneys to the types of centers that accept that kind of non-perfect kidney. Because remember, we're predicting whether each center would accept that offer or not based on a whole bunch of clinical variables, that particular center's history, and also that particular donor's age and gender and their creatinine, blah, blah, blah. So we know a lot of details about the organ. We can predict who we think is going to say yes to it. So again, comparing to right now, we have this 21% non-use. If you sort by reverse waiting time and you just give this offer to the person who has low priority, the person who's been waiting the least, then the non-use rate goes down a little bit, but actually offering them to the people who are likely to accept them would decrease non-use a whole lot. This is the most of anything we tried, and that's down to 9% non-use. So the idea of offering the kidney to the person who's going to take it would really work well. We are trying to also get these two papers out so that the kidney transplant community can debate them. But neither of those things happened, even though they've been proposed and discussed for years. No, instead, there was no policy, and the OPOs did allocation out of sequence. And allocation out of sequence means the OPOs looked at the order in which they were supposed to offer them and they said, nope, I think I'm going to call my friend down at NYU because I know they take a lot of these really hard to place kidneys. I'm just going to call them and see if they'll take it. And then I'm going to mark bypass for all of the other patients that should have been offered this kidney. This was kind of a scandal when it came out in the New York Times that a lot of allocation out of sequence was happening, and the OPOs were just using their own estimate of who's likely to accept the kidney. And it makes it really a lot more possible to place these challenging organs. And again, this thing took off at the same time that we're talking about, right in 2021, all of these incentives changed. And so the OPOs started doing 20%, 30% out of sequence. 30% of the kidneys skipped the actual line, whereas before that number had been about 2%. And HRSA told the organ procurement organizations to stop doing it. They sent out a scary email, and the number of allocation out of sequence dropped hugely, and so did the number of transplants. So we compared what happened immediately after this scary memo went out to same year reference, and that means what was happening in 2025 before before HRSA sent out a memo saying you should stop doing allocation out of sequence. And then we also have the same time period during a year before because there is seasonality of allocation and of donation. So just so we had some good, two good comparison groups. So the percent of transplants that went out of sequence dropped dramatically after this memo came out. After the memo came out that said stop doing out of sequence, that's in red. So the number of transplants that went out of sequence went from 30% to about 15%. So they really did dramatically decrease this process. And the number of kidneys that didn't get transplanted dropped also. So non-use went from, you can see about 28% to like 25%. But that seems like a good thing. Like the HRSA's argument had been that allocation out of sequence isn't preventing non-use, so you should stop doing it. And so it seems like that might be a good thing if the non-use went down. But what actually happened was that the OPOs that were not using out of sequence anymore, they stopped recovering marginal donors. So you can see the number of deceased donor kidneys recovered dropped a lot by about 10 per day from these OPOs that stopped doing out of sequence. And the number of transplants dropped. And we figured out that over a year, this study was about 6 weeks, but if that result was sustained, it'd be something like a drop of 1,500 transplants every year. So the warning, don't go out of sequence, didn't just affect how am I placing these kidneys, it affected which kidneys were getting placed at all, because some of those kidneys were not even being recovered. So that's an example of like a policy change that kind of had these unintended consequences in other places. We're beginning to realize one of the most intractable problems is that of defining problems, knowing what distinguishes an observed condition from a desired condition, and of locating problems, finding where in the complex causal networks the trouble really lies. So, did the trouble really lie with you shouldn't go out of sequence, or did the trouble really lie with we don't have a way to get kidneys aren't that are hard to place to the person who's willing to accept them quickly, right? Um, and even defining what is the problem. The problem isn't to decrease non-use, in my opinion. The not focusing on the number of kidneys that didn't get transplanted was kind of like leading our field astray. And again, you see the boundaries of this system have to expand. I haven't yet modeled in my discrete event simulator the kidneys that weren't offered because the OPOs didn't ask those families for permission and they never put them into the allocation system. But I think I actually should. And so this is an example of kidney non-use is a wicked problem. There's no definitive formulation, and it has no stopping rule. There is no way to say we have achieved a good level of non-use. I think there's also no way to say we've achieved a good level of like allocation out of sequence, but maybe if they finally took some suggestions about ways to redefine kidney allocation policies so that some of these kidneys would get placed instead of not getting used, we would be able to see that. Um, so there's no test of whether we solved it appropriately. Uh, Whereas in the tame problem, by comparison, we said, did we achieve similar distributions of organs going to the right populations within the liver allocation candidates? We could test whether we got what we wanted. But in the problem of kidney non-use, there's really no way to say we solved it or this answer is correct. We have these ripple effects that aren't reversible. And you can explain the wicked problem in numerous ways. Are we explaining that the problem is that the organ is not getting used, or are we explaining that the problem is that the organ takes too long to get to the person who would accept it? So why am I harping on this? Why am I saying it's so important to notice that this is a wicked problem? One thing is to anticipate the fact that I'm going to have to look outside of the aspects I have modeled to find the solution. And I'm going to have to recognize that I won't be able to declare my solution is correct or I solved the problem. Um, we can evaluate whether we improve the situation. It's better or worse. It's not like true or false. And one of the problems that's happening now is that the Health Resources and Services Administration that oversees transplant in the United States has put a hold on every allocation change that has been planned. So every possible way of improving the system for getting organs to the people who need them is on hold because they said first we have to solve the problem of kidney non-use and allocation out of sequence. So not until this is solved can we do anything else. And I find that kind of disingenuous and kind of like, well, that's problematic because that just means we can't solve anything because we'll never really know that we've achieved the ideal level of kidney non-use. You always want the organ procurement organizations to be making as many offers as they think there is any small chance that somebody is going to transplant that kidney. You know, patients benefit from the higher number of kidney transplants, even if some of the kidneys that get offered aren't transplanted. Yeah, so that's kind of the problem I've been thinking about a lot lately, and I thank you very much for listening and happy to take questions.
Well, thank you so much. This was a super interesting talk, and immediately when you started talking, I was thinking, do you ever batch offer or like offer and see who responds first. And it sounds like no, but that as optimizers is what we think of. So it's interesting to see how that could have an impact. And I'm curious to follow along with the work.
And the answer, why not? Why aren't they already doing these things in batch offers? The answer is that the organ offer and acceptance process is really labor intensive on the transplant surgeon's part. They're calling the OPO and saying, wait, tell me about that. Wait, how long was he in the hospital? Did he have
Hmm.
this infection? Can you show me the like lab results? And I need to look at the biopsy and see whether I think the person read it correctly. I mean, literally, it's a lot of detail of making sure because the physician is responsible. And it's even
Right.
written into the law that the government can't force you to accept this offer. The physician's responsible for saying, yes, I think this kidney will benefit my patient or not. And that takes a lot of time. And if you batch offer, then that means that I may have to do all that work, read look at the biopsy, look at the schedule, look at all of my patients. Say I've got like 100 patients on my list. I think it might be right for Mr. Jones. Okay, like let's go back and look at his thing. Well, what about his heart results? Is this going to work well? It's so detailed. If you have trouble with your heart capacity, then you can't have the vessels in the kidney can't be too occluded.
Hmm.
And so all of this stuff takes a lot of effort and time. And batch offering is asking multiple people to do that, knowing that only one person is going to actually be able to transplant the kidney. It's hard to, it would be a big cultural change too. Um,
Yeah.
so you limit it to like only the really hard to place kidneys. It's hard to know. I mean, we think it might work, but the devil's in the details of a lot of this stuff. But none of these ideas have been tried,
Huh.
unfortunately.
I mean, it is just like, yeah, yeah, you have to put it at scale, and it's hard to, you can't just pilot at one site a change to an allocation scheme.
Yeah,
So it's a
that's the
tough,
wicked problem part.
yeah, it's all the things you outline. I'm intimidated already. Um, there are a lot of other things I could ask about, but I'll look around to the group. I don't know if there are any questions from anybody in the audience. Either feel free to raise your hand or ask on chat if so. And a minute.
If not, I can just jump in to see. And thanks to this excellent presentation. I just would like to hear more from you about how is the future, where this things is going, and right now, what are you working on to expand or make the processes even better?
That's a great question. What am I excited about? I'm actually excited to dig into the processes at the OPOs of making these offers. I
Mhm,
had proposed some work based on process mining. If you've heard of this methodology, it's the idea of looking at the electronic logs of the times that
mhm,
various events happened and processes, and then trying to, in an automated way, turn that into a dependency map that says you can't do process B until after process A happens. And
mhm,
exactly how long each of those steps takes because the minutes matter here so much. And there have been some cool process mining papers where they identified, okay, the problem is that when the patient gets to the hospital, you shouldn't have to take them to another place to do the imaging for this thing. Like, okay, what we need to do we need to move the room where this happens to a different place, or we need to treat the patient in the room where they're doing the imaging, whatever it was. So
mhm.
it's kind of like drilling down into the really detailed geeky things about how long does it take to get the biopsy back and are the slides uploaded right away and are the physicians saying no, we're waiting for the result of test B and we didn't get it and could we get it faster. So I'm kind of interested in like digging into making the offers happen in the most streamlined possible way because I actually think it'll make a difference and move the needle for people who are waiting for a transplant. Yeah, and that would be cool because I'd be learning a new technology.
This
I
is
think we haven't,
great.
I think we haven't exploited process mining enough in the US. I really think that we're behind the curve.
Yeah, I was about to mention the system and the process oriented. I think it's come from all is IE background and the system thinking and very detail oriented about the system itself. So there are a lot of bottlenecks in there that could be
Mhm.
make the process more streamlined, as you mentioned.
Yeah. But I think there's like a lot of suspicion, I think, that operations researchers are drawn to problems in
Mhm.
transplantation, and the transplant community think, I mean, when you talk to a physician, they will always tell you why their patient is different from everybody in your data. That, well, but no, but you don't understand. My guy had this disease and was this happened to them. And so it's so interesting that, it's really hard to trust models built on, this big data thing and say, well, in general, we see this pattern. Physicians think about the one patient in front of them and how
Mhm.
different that mindset is. And that's why we say it's taking a long time to evaluate these offers. The physicians say, I can't just tell you, no, I won't take a kidney over 75. Maybe I would. Maybe if it was this kind of kidney. So yeah, it's a lot.
That's a lot and understandable. Yeah.
How, so like you were saying, there are many of these kind of offers coming through. Is there a, I don't know like what metric there would be to quantify this of like how often really a better offer does come through in short order? Like what is the regret of those? Were they right to wait or not? Do, do you have any sense of that?
I love this question. We actually do have a fair number of papers on this. In fact, we
Mhm.
have we have a whole series of papers that are called Turned Down for What?
I mean, you got to do the collaboration just to get that paper title.
The paper is literally called Turned Down for What? But it follows the patients who said no to an infectious risk disease kidney. And that's like for us, the stereotypical example of you should have taken it because infectious risk label from the CDC is actually a really, really, really tiny risk. And those kidneys are often from young donors and could provide a ton of benefit. So we showed that those particular patients who said no, we can see what percentage of them get a non-IRD kidney later, get a non-infectious risk kidney later. A lot of them do get a non-infectious risk kidney later, but overall, that more of them are dead 5 years later who said no than the ones who said
Hmm.
yes. But you're right. So we shouldn't be comparing it to take this kidney versus not get a transplant. We should be comparing to the appropriate case, which is take this kidney versus continue to wait and take a kidney later that has whatever
Mhm.
quality. And yes, we do use that method to analyze the data on patients who said no to things. And
Mhm.
overall, the message of almost all of these papers is there are there's almost always more benefit from saying yes. Not always, but like there are tons of people saying no to things that they should be saying yes to, and that's the
Hmm.
that's the overarching message.
Very
But
cool.
but then again, the transplant system isn't uniform, and you have some hospitals, they may not be able to take care of particular kinds of complications if they take this kind of kidney. And so we see good results from taking that kind of kidney because the centers that were well resourced and had overnight imaging available and blah, they took the kidney because they said we can manage the risk or the potential short-term complications that come out. And other centers can't. So it's a really interesting system to learn about.
And so complicated. I see why one can easily spend a career just like learning the details of this system. It's super interesting.
I was fortunate enough to marry a transplant surgeon, Dori Segev, and later, after we were married, we realized we should really be collaborating, and it's been a really fun ride. But yeah, I always have someone I can
Oh,
ask about the details. Like, what about this immunologic thing? Like, is this real? How important is this immunologic matching or not? Yeah.
that is a good connection. Good in-house domain expert.
Yeah, and good proximity.
Yeah.
Yeah, I'll
Proximity.
say it.
All right. We have one non-question, but just a Q&A
Comment.
comment.
Mhm.
A lot of appreciation for the paper title and the talk in general.
Yeah.
So, all right.
Thank you.
Well, if there's nothing else, I guess we'll wrap 2 minutes early, but thank you so much for coming to talk about this work. For all who are here, we have recorded the session and we look forward to having future seminars, generally the last Friday of the month. So stay tuned for an update on that. Thank you again for coming, and we look forward to following along with the work. So
Thanks for inviting me. See you later.
thank you so much.
Thank
Bye.
you. Bye.